inviting me to this event, and in particular Veronika for organizing this. So another Veronika, we have two Veronikas today. So hi Veronika, thank you so much for organizing this event, and I'm looking forward to more discussion about the important things that have already been said in the opening session of this event. And while listening very carefully to the presentations in the opening event, I was suddenly realizing how much my presentation actually links to many of these themes, which I think is nice for us as we go forward to see many things kind of reoccurring and create some themes and follow up on some themes in our discussion. So my presentation will focus on the promotion of generic medicines in Latin America. I will use Mexico and Chile as cases to illustrate the complexity of policy development and implementation. And here's already one theme that I want to link to, which was mentioned by Adriano, who put on his last slide the importance of the political part of policy implementation. And I will link to that and emphasize how important that is for these two cases that I will present. Why have I chosen these two countries? I have lived and worked in Mexico for 10 years. I have been based at the National Institute of Public Health in Mexico, which is one of the largest public health institutions in the region. And I'm a visiting professor there. I'm continuing my engagement in the region, and I've studied pharmaceutical policies in the region for the last 15 years. I've chosen Chile as an example because I'm now part of a study that is financed by the Alliance of Health Systems, Health Policy and Systems Research at the WHO. They are doing a study with the Ministry of Health in Chile on the introduction of the bioequivalence policy and the substitution policy. And because I'm just finalizing 2 manuscripts on that with the team at the Ministry of Health in Chile, I thought it might be very interesting to present some of the findings and some of my reflection, putting that into the perspective of the region. Just this year a bit to create a level playing field. We come all from different disciplines, and not everyone might be familiar with some of the terminology that we are using. Why the relevance? Why looking at generic medicines in this discussion of affordability? As you know, generic medicines are more affordable than originator medicines. They are on average 2 to 5 times the price of the originator medicines. We distinguish usually between branded generic medicines, those that are identified by the commercial or the distinctive name, and then we differentiate that from the unbranded generic medicines. They are commercialized under the generic or INN, International Non-Proprietary Name, that indicates the active substance. Then there is kind of like a complexity within that in Latin America, which is a term similares, which is not necessarily a term that is used in many other regions. And the definition of what constitutes a generic is dependent on the national legislation. So some countries have decided to name something generic only in the case that it has an approval of being bioequivalent. For instance, comparing this to the United States, for all generics, there is a requirement of a bioequivalence study. In Latin America, that is not necessarily the case. You have this kind of similares, which are a certain type of generics that might not have the bioequivalence studies, might not have the required bioequivalence studies. So it's important to take this into consideration as we go forward with our discussion on promoting generic medicines in the region. I have here summarized a compendium, so to speak. I've summarized selected policies to promote generic medicines. That is a compendium that is a generic that applies to all regions. That is not specially to Latin America, but I wanted to give you a flavor of that generic medicine policies actually is a mix of many, many strategies. And I've used here a way of classifying that, of presenting them in the way of area where you might implement them. Some of these policies have already been mentioned in the discussion, in our previous discussion. Anita particularly made reference to various policies that have been used to make medicines more affordable. Here I want to highlight in red 2 of the policies that I will speak about when I speak about Mexico and Chile. I will make reference to something where medicines are labeled
in the way that it makes very clear that there are generics with the bioequivalence studies approving, so to speak, their quality, being equivalent to the originator product. And then I'm making reference to the studies needed to prove bioequivalence. So I'm talking a little bit about a policy implemented in Chile to require bioequivalence studies. As you can see, the list goes on. There are many other policies that can be used, other strategies that can be used to promote generic medicine utilization. And I'm here making reference to two others on the slide. There are more from the demand side, from prescribers and the dispenser side, so to speak. One is the regulation to prescribe by INN, by International Non-Proprietary Name. That would be a strategy used to promote generic prescribing. And then another one is the generic substitution, which is a policy that is implemented at the level of the dispensing. So you could say pharmacy or drug outlet, where this is implemented. And I will make reference to that for Mexico and for Chile. One thing that we haven't mentioned, or maybe that was mentioned but more implicitly, and I want to make that explicitly before starting with the two countries and the comparison of the two countries, is that in Latin America we have also the distinctive feature of a very pronounced public sector, and differentiated from that a private sector. So what I mean by public sector are institutions like government, social security, which have embedded also the supply of medicines. And that means that people that use the public institutions are often also receiving their medicines within that same institution without co-payment. So you could kind of visualize that as a fragmented health system in which you have a public sector where even the dispensing side occurs in that sector, and then the private sector very distinct. In many Latin American countries, the access to medicines is mainly through the private sector. However, we cannot forget the public sector. For instance, for the Brazil presentation, we heard that there is a public sector with 20% in which patients get the medicines, and then another 20%, which was Farmacia Popular, which is somehow uses certain policies in place to very much influence the selection of drug used. And what I think is so important when we discuss generic policies to make that distinction, because what we see in the public sector is a much more stricter, let's say, regulation and also implementation of generic policies. So for instance, the mandatory use of INN within the public sector in many public institutions in Latin America, whereas in the private sector not. Or for the dispensing, a very strict formulary, guideline implementation, etc., whereas in the private sector that is not. So I think we need to distinguish that in our debate as going forward. But as we have a lot of utilization of medicines in the private sector, probably our discussion will be a lot about the private sector. So starting off, to give you an overview, and Veronika Vargas has spoken more about recent data, I just wanted to make the point. I did a study in the last decade, 2001, 2011, to just in general show how Latin America as a region was able to increase the use of generic medicines. And particularly what I find is interesting is the unbranded generics. So as you can see here, the share of generic medicines in total has increased, but particularly the unbranded generics have increased, which I think is a positive, in general is a positive development, because we know that unbranded generics are usually even less expensive than the branded generics. Here I want now to start with a comparison about two countries and contrasting them for selected generic medicine policies. So what I have done on the left is I selected some generic medicine policies that both countries have decided to implement, and I here marked whether these policies, in which way these policies have been implemented so far. So one is, for instance, the bioequivalence requirement. In Chile now, this is in place, as Veronika also mentioned, for selected active ingredients, for selected molecules that is in place, and there is a demand for a bioequivalence test in order to have that pharmaceutical active ingredients approved as a product. For Mexico, that is mandatory for all generic medicines. In other words, in Mexico, we have only two types of products. We have the originator, whether patented or not, and we have what we call generic medicines. We do not have similares anymore, whereas in Chile, that is still the case. As we go forward, we will see there are still products in use that are called similares that do not have, legally, do not need the bioequivalence requirement. Then we have generic labeling, the labeling that I made reference in my previous slide. In both countries, we have the requirement of labeling them. In the prescription, on the prescription side, the use of the INN is still voluntary. Substitution is voluntary. That means it needs to be initiated by the patient or by the user of the medicines. They need to ask for substitution. And then we have some public campaigns in both countries, but I labeled that here in Mexico. I classified it as extremely limited. So we don't have large public campaigns to promote the use of generic medicines. So the first example that I wanted to talk about is Chile. Chile has implemented the bioequivalence requirement. It is relatively new, although some decrees have already been published in 2014. But specifically from 2012 forward, some of the kind of deadlines have now expired for manufacturers to get their bioequivalence approval. For instance, for a decree that was published in 2010 with a list of certain medicines, they had then to acquire all bioequivalence approval by, let's say, 2012. And now from 2014 onwards, we did a study and looked at how many of the medical product that actually should require bioequivalence tests, how many of them actually acquired them. There is also an exception made. Some also only need to have in vitro testing for their bioequivalence studies, some in vivo, but there is an exception for some to have only in vitro testing, which is usual for these types of regulations. Then we have, since 2014, the regulation of generic substitution at the point of dispensing. But as you can see, the physician can add, if he wants, the INN in addition to the brand name. If the INN is not added, then no substitution can take place. And in addition, the patient needs to request the substitution. So here's the first result of what we have looked at by looking at just the registration data. We were interested to find out, when I now have a deadline and know X number of products with a certain pharmaceutical active ingredients have to have biomedical bioequivalence testing, how many out of those have? And you can see here the number of molecules that we looked at, the number of active pharmaceutical ingredients. We looked at a bit more than 100. And out of them, you see here kind of like the percentage out of the medical products having that active pharmaceutical ingredients, how many have actually reached bioequivalent. I would have expected, I mean, from a theoretical point of view, you would have expected by a deadline, all of them should have it. But what you can see, only a few actually comply in a very over 80%. But we have also some for which we still do not have any bioequivalent products approved. So the rest, in other words, is still on the market as similares, although you would, from a legal perspective, say these should now have bioequivalent testing done and being certified as bioequivalent. Then we did another part of our analysis in the study was looking at what has happened now with the volume uptake. So one was looking at the legal requirements, one was now looking at how has this been played out in the uptake of bioequivalent product as being substituted for the originator. So we predicted some kind of effects from a theoretical standpoint. You might want to, you would argue in saying, once I have a substitution policy in place, what I would expect is that my originator product sales goes down and my bioequivalent product sales would go up. So you want to increase that and you want to decrease the originator sales. What we have seen then in our study is, yes, there is a decrease, but we haven't seen an uptake. We haven't seen an increase in the use of bioequivalent product sales. And in a minute, I can give some kind of hypothesis why that might have occurred. And then the bioequivalent product prices, the policymakers with whom we worked at the Ministry of Health hypothesized an increase. Why an increase? Because they were saying with more costs of testing the product, we think that the product prices of these products will go up. However, we didn't see any change in our analysis. So, coming now to the next country and looking at what has happened in Mexico with with policies promoting generic use. Mexico has introduced for a long time already the bioequivalence requirement, but the deadline was 2010. By 2010, all the products that are labeled as generics have to have bioequivalence requirement and kind of like an outphasing of the similaris products. And then in terms of regulation of generic substitution at the point of dispensing, that came into effect more than 10 years ago, so we have already a long time where this is in place. But still, the physicians can add the INN on the prescription, but not necessarily have to have it. Then the patient can request the substitution, but it's not mandatory. So what has happened in terms of volume, just to give you a glimpse, we have a very high volume uptake in the public sector in terms of generic utilization, and this is very likely due to, as I said to you, to the much stricter, let's say, policy implementation to promote generics in the public sector, whereas in the private sector, yes, it has increased in recent years, but is not as, let's say, as effective as in the public sector. And also in terms of value, we have a lower share of generic medicine value in the market. So kind of like in terms of concluding or my kind of observation on these two things, first of all, I think that the incentives that prescribers are given to still prescribe and continue to prescribe by brand name is an important one to recognize. It's an important one to recognize how influential and vocal this group is, particularly in Chile. I was told by the Ministry of Health that there has been an attempt to change that regulation, but was not successful because of that barrier from the physician side, the kind of vocal resistance to changing that. Actually similar to Mexico. And then also the pharmacies have been resistant to have that as a mandatory substitution. They have certain incentives to keep certain brands, and even certain branded generics, because there are chains that produce their own branded generic products, which they would like to sell in their chains. Exactly similar between Mexico and Chile. And then we have the asymmetry of information. I showed you in the beginning that Chile has made some attempts to promote the use of generic medicines. However, that wasn't that strong or isn't that strong in Mexico for the private sector. So there is a lack in general, I would say, in many Latin American countries of a strong advocacy group. So patients as advocacy group, I think there's still a lack of that strong advocacy from the patient or from the consumer side of point of view. So in summary, political challenges, I think, are extremely important for us to discuss as going forward, taking them into consideration. We saw the importance of very vocal groups and groups that have commercial incentives to keep certain policies in place. And I highlighted the role of physicians and pharmacies in my presentation, but there are certainly also other groups, and some of the presenters before me have highlighted that. And further reforms need to take that into consideration. Thank you very much.